we're still having people coming in.
Hey everyone, we are letting people in and we will get started in just a couple more minutes.
Okay.
So great to see so many people joining.
I know. All right. Thank you for joining us, everyone. We are the Endometriosis Foundation of Houston. Thank you for joining our special endometriosis awareness tea talk with our very special guest, Dr. Xiaoming Guan. Okay, can I get a raise of hands, sound off in comments? Who here is a patient of Dr. Guan? I see some hands. I see some people in comments.
Hi.
Awesome.
Hello.
All right. Well, we are glad to have so many of his current, former, and hopefully future patients. Thank you so much for joining us, Dr. Guan. We're really excited to have you here talking with us today. So I'm going to go ahead and introduce our special guest. Dr. Xiaoming Guan is the Chief of Minimally Invasive Gynecologic Surgery at Texas Children's, and he is an Associate Professor in the Department of Obstetrics and Gynecology at Baylor College of Medicine. Dr. Guan earned his medical degree at Fujian Medical College in China, and he completed his obstetrics and gynecology residency at St. Joseph's Hospital, a Mount Sinai School of Medicine affiliated hospital in Paterson, New Jersey, followed by a fellowship in minimally invasive gynecologic surgery at Baylor College of Medicine in Houston. Dr. Guan brings extensive experience in treating complex and challenging cases of endometriosis, uterine fibroids, and pelvic masses. He is a leader in minimally invasive gynecologic surgery and a pioneer in the use of state-of-the-art robotic single-site technology. He is Houston's top endometriosis expert and serves on the advisory board for the Endometriosis Foundation of Houston. And most importantly, he's my surgeon. So thank you so much for joining us. Dr. Guan is going to give us a presentation on endometriosis, and then we're going to save time at the end if you have questions. So I will hand it over to you.
Thank you, Alison. Thank you for all the funders and everyone from the Endometriosis Foundation of Houston. I'm very proud to be and honored to be one of advisor for the Houston EFH and Endometriosis Foundation of Houston. And we have so many patients and in endometriosis in Houston because we are the almost third one. Now it's fourth biggest city in Americans. Obviously, we're going to get to possible overpass the Chicago will be number 3. So based on this instance, that's why we have so many endometriosis outside there. I'm so honored to have a chance to talk to everyone, and hopefully going to have, after this lecture and question and answer, going to help everyone know about endometriosis and know how we treat endometriosis. And obviously, if you have any questions and concerns in the future, we hopefully in my practice, we can address it. And we hope we can expand our program for endometriosis and to create an endometriosis center and help them. Hopefully can help more patients from Houston and out of Houston. Actually, I have 1/3 of patients out of Houston. So, okay, I'm going to share my screen for the brief lectures, give some brief information about endometriosis. So, and basically, this is endometriosis, March for Endometriosis Month, and endometriosis awareness. And I asked Alison to collect something for me. And actually, what patient interested, you guys interested, and actually come up with the recurrent pelvic pain. Actually, this is a very broad and difficult topic. So that's why this time I'm going to focus on this. And I think this, in the future, because we have this wonderful, great society and for Endometrial Foundation, right? We have more opportunity to promote this kind of, we can give more lectures and talk about and discussion about other kind of endometrial related topic. Endometriosis, if you want to give a lot of talk, talk, you can talk 24 hours, even not finish. So that's why we're going today, for this brief time, we're going to talk about recurrent pelvic pain. This is all the question patient going to ask. So what's endometriosis? Basically, endometriosis, all I don't know, most of here audience know what's endometriosis because this is the kind of talk we're going to cover a little bit, the definitions. So endometriosis, endometrial cell outside of uterus. So this is a word. It's not in the location you're supposed to be. Then what happened? You're in a different location, right? Then you cause inflammation. So I think inflammation is kind of broad name and kind of terminology for medical terminology. I think everyone get infection, right? Occasionally we are cut in our finger or somewhere cut. What happened to that? It causes swollen, causes the kind like a discretion, some discharge, then everything deformity, right? This is happen exactly in other location when endometriosis happens. So it's not in the, supposed in the uterine lining, but outside the uterine lining, you can into the bowel, into the peritoneum, into the ovaries, fallopian tubes. So that's why I come up with the most common location. Where is that? So actually most common location is the location around the uterus. It means what? It means bladders, ovaries, fallopian tubes, and the bowel. Basically, is rectal area. And all this area covered by the peritoneum. So this area can inflame. So persistent, every month, your period, you have inflammation there around with the time. So this accumulation causing the kind of fibrotic tissues and scar tissues. When you form in the scar tissues, and you can cause in the pain, or some patients not causing pain can cause infertility. So, and then there's one of a paper published by Dr. Maham. So basically it's that one review pathology specimen reports reveal that endometriosis has been identified in nearly all human organs. So that's why a lot of patients come to us and say, hey, Dr. Guan, I have endometriosis in here, in my lung. I have endometriosis in the chest. I have endometriosis in the diaphragm. How come I'm endometriosis on the abdominal wall? I did not have any surgery there. So this is the why. So you can explain, right? Pathology find everywhere, can happen to anywhere. I still remember when I applied for fellowship, I went to one of the endometriosis pioneer in Georgia, is a Sina Nazar. So he asked me one of questions. He said, Dr. Guan, do you know which organ no endometriosis? So that time he told me it's a spleen. I don't know, obviously. That's why I did not match there. So I did not do the fellowship there, but he's great in endometriosis. In Georgia, I have plenty of endometriosis surgeons, great. And what kind of endometriosis symptoms we have? And because this group endometriosis, most times the patient have pain, right? So, but actually have.
I like pennies.
And actually have around 30% patients have endometriosis without pain. We have one of our physicians who find endometriosis by what? So one day she had a UTI, have a pyelonephritis, that's a kidney infection. She went to ER. And her husband is a radiologist.
Alison, you are beautiful.
So then what happened? They did the culture and find out infection. They did a CT scan and find out have a basically it's a hydronephrosis and have water in the kidney and urethra and complete blockage. She have zero pain. That's why she doesn't know. So she came to me, we have to do the resection, the full stage for endometriosis, remove part of urethra. So this is the kind of patient have no any symptoms. However, that's around 70% patient. Most common symptom is in the pelvic area. So everyone is speech and that kind of pain during the period.
Alison, you are beautiful.
And also, and some patients cannot get pregnant, so causing infertility. And occasional have endometriosis in the ovary. This is the one imaging can find out have the ultrasound show have ovarian cyst. They sometimes because of character of this component of this endometrioma is blood. So that's why ultrasound can identify, they give diagnosis for endometrioma. And also a lot of patients have sexual pain. So, and who is the vulnerable is the risk for actually can have endometriosis? Who is suspicious? So this is from a Medscape. So give a laundry list. So one is the family history of endometriosis. This is really true. I have patient twin. Both sisters get the endometriosis, sibling, right? So have mom have endometriosis, you get the endometriosis. So or you have other relative, first related relative get endometriosis, you possible get endometriosis, big chance. And early age of menarche, this is a kind of, it means you when you start a period like, used to be when you start a period like 10, 11, 12, now have a kids start a period like age 7, 8. So this is the risk too. And short menstrual period. So it means you normally say every month, 28 days, right? You have 14 days, you have more risk. And then if you have periods, normal periods less than 7 days, but even more than 7 days, you increase risk too. And always the heavy period. Heavy period sometimes around with the pain, we call dysmenorrhea by the medical terminology. It means painful period. This is a risk too. And if you get pregnant less, so inverse relationship to parity, it means you only get 1 pregnant. Other people get 5 pregnancies. So 5 pregnancy people less chance can get endometriosis than 1 pregnancy. However, it's increased risk for adenomyosis. That's another risk. Delayed childbearing means you suppose you get maybe 20, 25-year-old, you get pregnant, then you just get to pregnancy like 40-year-old, you more risk. And defects in the uterus and the fallopian tubes. This kind of is defect, it means you have C-section, right? Or you have a anomaly in the uterus and fallopian tube, you increase to be risk for. So this is common question a lot of my lovely patient ask in the first visit. He said, why I can get, who can get it? Sometimes they say, oh, my daughter's, I have endometriosis now, my daughter have risk. Yes, you have risk, but not definitely your daughter going to have. This kind of general information, I hope everyone understand. Now, a lot of questions show up is what's the reason causing that? This is really $1 million question. So actually no single series explains all cases of endometriosis. There's a symptoms, retrograde menstruation, and genetic factor. Actually, Dr. Redwine, I listened to his lecture, it's great, wonderful, our pioneer of endometriosis. And I remember it's Nancy's physician, I think. His lecture is great about embryonic origin of endometriosis. I believe this one too. So that's why I believe complete excision of endometriosis is the treatment. So because you need to get the root of why you forming endometriosis. Always there's some more you can from a laundry list, immune factors, and also lymphatic, everything. So let's a couple of times that people that are in the medical area we're talking about. If one of a disease, you have multiple treatment, so you don't know which treatment is better. It means what? None of them is good. So the same, if you have a disease, have multiple theories, none of them we know which one is the best one. So it means none of them theories can explain everything. So we have to use all. So diagnosis, that's another question from a lot of audience. So endometriosis can diagnose it by the ultrasound, X-ray, MRI. So then we tell them, they say, no, it's normally only endometrioma can find it. Then another question show up. Then why we do MRI? So MRI or pelvic ultrasound, it depends on which facility. Some facility very good use the ultrasound to do the diagnosis of endometriosis. We call deep infiltrated endometriosis. But in my society, in my hospital, basically radiologists, they good in MRI to diagnosis. We have used different type of put the gel in the vagina and rectum to do the diagnosis, get the better result. I find out it's pretty consistent with my surgical diagnosis. So that's why we use that. Obviously, you go to any specialist, they have their own which one is better. Actually, not means MRI is better than ultrasound. Just which facility, which diagnosis test they get more used to it. And then we do the MRI or ultrasound based on we're looking for a lot of bowel endometriosis and deep infiltrated endometriosis. Deep infiltrated endometriosis, that's what that means. It means if you have, this is from one of our physicians, Dan Martin, is our pioneer of endometriosis. I'm lucky a couple of times go to meeting with him. And he's a great guy. And he basically wrote an article about definition of deep infiltrated endometriosis. It means a lesion more than 5 millimeters. So, and actually, based on this definition, a lot of our patients have deep infiltrated endometriosis in different locations. So this 5 millimeter deep infiltrated endometriosis, a lot of time can be diagnosed by MRI. That's the reason you cannot be definitively diagnosed, but we offer it because this is going to give a guidance of when we're doing the surgery. So what's management? So obviously, I'm the excision surgery. I recommend complete resection of endometriosis. And then another one, so you see from the location, you can tell it's multiple organ involvements. So that's why you should go to the facility, have multiple disciplinary team. It means you have colorectal surgeons, you have urologists, you have thoracic surgeons. So this kind of surgeon is not the first day they know endometriosis. How we train them? Basically, when I just start with endometriosis, I call them and I say, okay, you come. Then at the beginning, I always stay there. I say, oh, this endometriosis should remove, that endometriosis should remove it. Then when along with the time, they also expert in endometriosis like colorectal surgeon. We use, we have two colorectal surgeons. One is Eric Haas and Dr. Ebert from Baylor. And urologists, we use the Dr. Sani. And the thoracic surgeon, we use the Baylor's Dr. Retrieval. They now all good at that. They know, look at, when I stay there for endometriosis surgery, they say, oh, this is endometriosis, I agree. So that's why it need times, not just the first colorectal surgeon coming and say, oh, this is endometriosis. Sometimes they can neglect the endometriosis. They think about it's not typical. The same as other gynecologists. Sometimes they can neglect. So now we get to the point. So relapse. So recurrent pain. So it's frustration to patients as well as physicians. And when patient came back to my clinic, they said, Dr. Guan, I have pain first thing is, oh my God, I have big head now. Pelvic pain coming back again. What's the reason? So actually, when patient asks this question, they think, well, what's the reason? Is the endometriosis coming back? And this is the same question we ask ourselves. This endometriosis coming back or not? So that's endometriosis specialist in the book, Dr. Martin Seelan. He's talking about 5 kind of endometriosis recurrence. Is that this is because of chronic nature of disease itself, ineffective medical treatment, and you think about premature discontinuation of effective medical treatment. Another one is inadequate surgical treatment, and then incomplete surgical treatment. I give 5 parts of that based on my own, so around 11 years now, surgical treatment and endometriosis. And I think first one is pre-op. You need to looking for the pain from multiple compartments. It means from multiple organs. We're going to address this later on. And then second one, I agree. In the OR, have two things happen. So inadequate surgical treatment and incomplete surgical treatment. Then post-op, what you're looking for, non-endometriosis pain. You're not just looking for endometriosis pain. The last one we should looking for is endometriosis recurrence. Because as endometriosis specialists, we training for complete resection endometriosis. So if we look at our surgical picture, we did remove our endometriosis. While coming back, we're looking for other sources first. Then we look for the recurrent endometriosis. So we go to looking for the pain from multiple compartments, right? So let's actually one of endometriosis specialists, Dr. Maurice Chang from Mercy's Hospital. I went to lecture with him, I think a couple of times in China. So he gave lecture, always find a cofactor pelvic pain. He said up to 30% to 50% patients have pelvic pain, not just endometriosis there. Patient possible have kind of pelvic floor muscle pain, kind of have interstitial cystitis, sometimes irritable bowel syndrome. You need to look into it. So that's why we, in the pre-op, right, we ask patients a lot of questions. Why? Because we want to identify not only endometriosis. You come for pelvic pain, we're looking for all kinds of sources. Then always to have endometriosis is one part of them. And then non-endometriosis female reproductive disease. So fibroids, ovarian cysts, a lot of things. And then the pelvic congestion syndrome, that's another one. Pregnancy can be the risk. So a lot of patients, they not, physician, they just looking for endometriosis, but they forgot to looking for other pelvic congestion syndrome. You should, in the surgery, you should address this problem at the same time. Then sometimes have pudendal nerve pain, have genetics of always the dancers. And GI is the irritable bowel syndromes. So this is one most common causing the pelvic pain. And urinary symptoms and interstitial cystitis, that's we ask patients all the time, and pelvic floor muscle pain. So if we're talking about incomplete surgical treatment in the OR during the surgery, so actually if your patient have adenomyosis and also have pelvic congestion syndrome or other disease, you only remove endometriosis. So it means you incomplete surgical treatment. However, so pelvic congestion syndrome, obviously we can treat it at the same time, but adenomyosis, until now, still hysterectomy is still recommendation. But a lot of patients, we looking for fertility. We want to keep the uterus. So this, how address this one, we should discuss about some, if we go in, remove endometriosis, we keep the uterus, but some pain or period pain can be still there. But then recommendation, we normally ask patients like mommy said, oh, you should get pregnant soon. So hopefully, so you get after pregnancy, if you the adenomyosis is getting worse, sometimes we maybe end up with, we have to do the hysterectomy. But if no adenomyosis, it means you don't need hysterectomy. Hysterectomy is not a treatment for endometriosis. Hysterectomy is the treatment for adenomyosis. A lot of patients go into, then a lot of patients say, oh, you should remove uterus. But if you know adenomyosis, you not necessarily need to remove it. It's wrong to remove everyone's uterus. And this is the pelvic congestion. I talked about a little bit. Maybe everyone get the information. What's pelvic congestion syndrome? So let's put it this way. Actually, this is similar to ovarian vessel dilated. And based on ultrasound MRI, they can find out it's more than 6 millimeter. And what's this disease really what? And let's say maybe everyone know about varicosis in our leg, right? In our side or lower part of leg. So it means the vessel dilated. Exactly this, if this happens in the pelvic, in the ovarian vessel, this causing the congestion. So how this happen? A lot of time because pregnancy. So when you get pregnant, you have big uterus, you compress the vessel, the vessel dilated. So after you deliver the baby, most of the patient, most of vessel, the flow get back to normal. They return to the heart. So that's why they not cause the vessel dilation. So then pain go away. They're not going to cause pain. There's a very small amount of patients have this kind, vessel still dilated. So then cause the pelvic congested. When you like a traffic, right? If you have not traffic, let's talk about this way. If you have a cardiac or you have something like a tube congested, when you congest the accumulator, then the tube get dilated. So this dilation of tube can cause in the pain. So that's why, like a similar concept, I try to explain to this because this is two medical terminology, pelvic congestion syndrome. So now get to the treatment. So treatment of pelvic congestion have two kinds of. One is the embolization from interventional radiology they can do in that. This good thing is this is very minimal invasive. Another downside, if you have endometriosis, they cannot treat it in the same time. So then the other surgery is called ovarian vein ligation. So this one is the one can treat it from the surgery with commitment with the endometriosis. We can remove endometriosis to the ovarian vein ligation. This is a lot of patients I've done it for our patients have both disease. We do a surgery. This is one of paper my publishes case report. We done more than case report, obviously. We done many of this kind of case. So this is how we doing the final vessel dilated. You see from the ultrasound MRI, you can see the dilated vessels when. So we go in with the green dye to identify which vessel, then we tied it, then patient pain will go away. Okay, so then another one is in the OR is inadequate surgical treatment. So this different called incomplete and inadequate. Incomplete means you know something there, you did not remove it. And inadequate, you don't know because one is the concept, another one is your skill or your surgical. You believe ablation is better than excision. So ablation is a good surgery, only if some certain stand not happen, like this kind of iceberg effect, right? If you only see the tip of iceberg, you burn it, you not remove the, you see a base is still there, always the pain still there, endometriosis there, still there. Then overlooks the subtle lesions. So with some very minor with subtle lesion in the medical terminology is that kind of atypical. So everyone know, right? Everyone know. If you have powder burn, everyone know. Even yourself, you know this is endometriosis. But some endometriosis like lesions, like small, like a color change or hypervascularity. A lot of physicians, they think about this not endometriosis, but actually they are endometriosis too. So third one is the ovarian random. A lot of physicians, they said, okay, I do the surgery and I remove everything. I remove uterus, I remove ovary. Why is hormone still there? They still have estrogens. Why my pain coming back? Obviously, you left this piece of ovary there. This is actually this surgical treatment is very difficult. You really need to go to specialist to do it. And another one is the endometriosis on the vital organs. It means what? in the ureter and bladder and bowel. We have a lot of patients come to see me that show up with a great picture. Then they say, oh, this is my physician told me there's a couple endometriosis on the ureter. I'm not comfortable to remove it. That's great. Actually, I appreciate. If they're not comfortable, they should not remove it. But in the same time, they refer to other physicians comfortable to do it. That actually should be the one called inadequate surgical treatment. So basically, you did not remove the one. So we talk about a little bit about excision surgery. Then because I prefer excision surgery for all my patients. So that's the abrasion surgery come up with, you see, this is a 2001 Jones publication. 74% of patients had a recurrent pain at average of 20 months, less than 2 years. And Dr. Redwine and other physicians published up to 7 years post-op with 57% cure rate. And it means recurrent rate only 43% in 7 years. So that's 2 years have a recurrent rate 74%. So that's why obviously all this excision surgery is better. So this is another one that you see 57% and 57% by other research, not only one research, not only Dr. Redwine research, actually other research prove it too. So about some of endometriosis, I want to use this video I post on the YouTube, and actually Nancy so nicely and post on the Nancy St.Luke group. And some, I don't know if you don't like it, don't watch it. So I want to give some the idea about some of atypical, right? It's the subtle endometriosis. You see like these lesions have fluid collections. This is kind of very typical, everyone know it. So this is a powder burn. So this is yellow color. So you see this is a kind of window. This is all endometriosis I've done, and pathology prove it. It's endometriosis. You see this hypervascularity, you have to remove it. Otherwise it's going to be there. You see all this filming, and this is endometriosis in a different locations. So if everyone interested, you can go to YouTube, and also Nancy St.Luke, I think have that. So this is kind of a typical endometriosis. And the other one is a difficult disease about ovarian random I have for my patient. So one of patient from other states, and she traveled all the way to Med Center. Actually, it's to MD Anderson. MD Anderson sent to me. So basically, she had a multiple surgery. One of GYN oncology did remove all the organs, ovarian, two ovaries and uterus, and endometriosis. After surgery, she right away still have persistent pain. She came in with the wheelchair. She could not stand up. When she told me she walked, she had to bend over. So that's why then MRI show have a 4 centimeter cyst. So I went in to do the surgery, and I find out this is ovarian random. Basically, they did not remove ovaries. So have 4 centimeter pathology show ovarian random. And this endometriosis like a plaster on the vessels. This endometriosis on the uterine, external iliac vessels. So this is a very difficult surgery. We remove it, and she got much better. So this kind of endometriosis is like an example of inadequate treatment. If you only remove uterus and ovaries, and always this patient, even if did not remove ovaries, you tell patient to remove ovaries, always the endometriosis still there. So now about post-op, if post-op coming out, my patient showed me, say, oh, Dr. Guan, I have endometriosis pain. I'm not looking for recurrent right away. What am I looking for? I asked patient, I said, you have ovulation pain. Sometimes the patient have a side, like every month, certain time have 2-3 days pain. That's ovulation pain. Then you're looking for have a couple of years, maybe you have fibroids and you have ovarian cyst. Then if patient we know have adenomyosis, then we should explain to mutual understand. You ask I'm going to ask your pain release and better or not. So that's why if only period pain during the period, then we explain this possible adenomyosis. We're going to taking care of, we can use the medical treatment, everything to try it. So some patients maybe have adhesions. So adhesion causing pain is still a lot of controversial. But however, my own experience, I did many patients coming in for suspicious endometriosis, we remove it. Pathology did not diagnose endometriosis, only adhesions, but we remove all the adhesions and put a adhesion barrier. This is the only time I put an adhesion barrier. So if patient have adhesions, so then a lot of patient pain go away. So I believe adhesion in certain location and certain type can cause the pain. Then obviously we're looking for other compartments like interstitial cystitis, irritable bowel syndrome, and pelvic floor muscle pain. If this happen, like we can send to PT, urologist, or send to the GI. So then last, now I post up, I say, oh, then if we rule out everything and we try the medical treatment, still not work, then we have to consider is the pelvic endometriosis recurrence. We do the surgery. Then this is unfortunately we have to do another surgery. So this is the kind of situation. And we, in the clinical visit, we always discuss about hormonal therapy. So always all this hormonal therapy medication have a lot of side effects. No one like it, I don't like it too. And I searched the literature, right? So again, and actually this is the one of recent literature, 2021 from Jahari. So that hormonal suppression should be considered patient not seeking pregnant immediately after surgery, right? Reduce the pain, recurrent. This is a literature support. And all kind of hormonal agents have been shown to be effective. Unfortunately, this is have a lot of side effects. So another one is from Europe, the Society of Endometriosis. They also talking about this. They find out it's like a short-term hormonal therapy up to 6 months, not help. They have to long-term hormonal therapy. It means up to 18 to 24 months. What kind of hormones? OCP, GNI, Mirena IUD, progestin. Unfortunately, all this medication have side effects, obviously. But this medication, obviously, from current literature, it really helps to prevent the recurrence of pain. So obviously, if no side effect possible, this medication will help. And we're going to quickly end this. So ready to see us? And this is a laundry list. Everyone, if come to see us and can look at that, what you need to prepare. I not go through it, waste everyone's time. So another one is how we manage our surgery. We want to clarify a lot of surgery. After surgery, we're not looking for right away have pelvic pain release. A lot of patients still have pelvic pain in first weeks up to 6 to 7 pain level, second week 4 to 5. And the cervix, I always tell patients, you possible get much better. So, and a lot of patients confused. They come in and say, okay, I have surgery. After surgery, right away, my pain should go away. It's not going to expect that. Especially when you have more endometriosis, remove it, and more pain in the first weeks, because you need time to heal, right? So it's the common sense. If you have a burning outside of your body, if burning area is large, so you expect healing time is longer. And so we normally suggest patient have using abdominal binder up to 6 weeks. And obviously you can go home same day, ambulate, except you have bowel resection. And also no heavy lifting, no sex, and no bath for up to 6 weeks. This in general, we just want to deliver here and everyone see it. So actually, I think now is everywhere doing a wonderful job. It's not from the physician, it's from the organization and from like you guys, every one of you help actually, and patient trust yourself and your friends more than us. If you tell them story, they trust, they believe, then they seeking for. And then this is really true story about a lot of our patients tell a story to neighbor show up and find out, hey, this is endometriosis and their treatment. And we have patients come out and they not, obviously not in the Endometriosis Society of Houston, right? In the Foundation of Houston, they don't know. The neighbor told her. So she came up and she had pain so almost 10 years. I did the surgery, stage 4 endometriosis, finally no pain. She said, oh my God, no one tell me before. Eve told me I should done it 10 years ago. So this is how you help other patients and friends and help, in the same time, help everyone. And this, another one is that everyone know this is chronic disease. It can recurrence. It's not like kind of one-time surgery and you never go, you always go away, but have certain amount of patient can come back. And always, I think still suggestion everyone looking for endometriosis specialist. And we call specialists because they were basically more experienced surgeon, not specialist. If you do more, you always see more, you do better. Because you see, we doing a lot of surgery. Every week I doing like 6 to 8 surgery. And now up to every 5 to 6 surgeries endometriosis. So some physician if you do like 1 week or 1 month, 1 endometriosis, always no, I'm better than them. Always I'm more experienced than them. That's why we can remove thoroughly. And medical treatment, and this is the, if no side effect, I still think about medical treatment we should consider after surgery. And try not to do surgery all the time doing surgery. not you need to skip the unnecessary surgery. We have one patient, I did 15 surgery, I think. So she told me every 3 months, her physician done her surgery. One time they took some from this tube out, another time took some from peritoneum out, and so many surgery. So this is really, really waste and increased risk for complications. So you only need to do the surgery you necessary, not just because I have endometriosis pain, I should do surgery all the time, no. So I here need to thanks again for appreciate and thank you. Thank you everyone for Endometriosis of Houston, Foundation of Houston, and organize this. Like Alison contact with me all the time, and appreciate Nancy Snook and Nancy herself and contribute this great contribute to this society and patient awareness and so many organizations, and also all these endometriosis specialists and endometriosis pioneers. I learn every day from them, even joining all these meetings and every day educate myself and appreciate them and all the patients. Without your everyone, we cannot improve our skills. And we treat you guys, we got a lot of rewarding from your guys. And I appreciate my department, really support and want to create an endometriosis center for us. And always my teams, they do a lot of job, a lot of burden, especially in this COVID time. So we have a lot of workload here. Hold on a sec. So, and this is Alison, thank you. Thank you for made this shares and everyone's here coming. And yesterday we have a team, our team. This is the nurse stories, and this is our call center director. This is our medical assistant. This is my administrative. This is my fellow. She's going to join my practice as always do endometriosis surgery in August. Tamisha Coithon. So in the future, everyone, hopefully we can taking care of more endometriosis patients in Houston, and you guys don't need to travel all the way to other place. Obviously, if other place do better job, you guys should travel too. So another one is I really thanks for that Guan Gens, and I'm obviously very happy about that. And I look at that. Actually, I'm more happy when I heard you guys result is better than Guan Gan. You guys tell me, it's I got pregnant. One patient told me, Dr. Guan, every time I do the surgery, I got pregnant. So she had 2 babies now. So I'm very happy about it. It's more rewarding. And I look at that abbreviation, Guan Gan GG, right? And actually it's good going, well done. So Endometriosis Foundation of Houston, I think about is the GG, right? Endometriosis GG. And when I was little kids in China, I'm from China. So when I got to the grade school, or I like a top one in the school, or I have a lot of achievements, what we got a reward? We got an egg. So the egg from the parents, they said, oh, you great. This egg rewards. Actually, this is kind of egg reward for myself. And when I heard all my patients get to very happy and get pregnancy or pain-free, I really get very happy. I think I should reward myself one of egg. Okay. So maybe you can make a logo for endometriosis GG. So go there and so for that. So just relax a little bit. One of a small video. Never underestimate endometriosis. So this is just a little bit funny video. So as when we do the residency, we do when we finish when a baby to cry, we always feel the baby's the butt or chest, then you're going to kick back. So this is kind of funny. That's never underestimate endometriosis. Endometriosis create a lot of problems. We need more awareness. I don't know. I did not look at the time. I don't know what's the time. I finished lecture. Thank you all.
Thank you so much, Dr. Guan, for your really educational lecture. I know I certainly learned some things that I didn't know, such as pelvic congestion. And I think you hit on a lot of really important things that so many of us have experienced, especially inadequate treatment. So we're going to go ahead and take some questions from the chat. Let me just pull up here. I know we had one question about what's the difference between deep infiltrating endo and stage 4? Is deep infiltrating going to necessarily be stage 4?
Actually, this is a great question. So endometriosis stage 4 is based on this kind of staging. It's American Society of Infertility. So basically, they based on advanced stage, more involvement in the ovary and the tube. But deep infiltrated endometriosis is the different concept and staging. There's a sense staging for this deep infiltrated endometriosis. It involved in locations. So you can have stage 4 endometriosis in deep infiltrated endometriosis, yes. But you can almost all of stage 4 is a deep infiltrated endometriosis. But if you have a deep infiltrated endometriosis, doesn't mean you have stage 4 endometriosis.
Okay, so you can have one without the other necessarily. Okay. There was a question about, going back to what you said about having the patients who have adhesions but no endometriosis. Did you mean like someone who previously had endo and now they just have adhesions, or is there something else that could be causing those adhesions?
So this have two types of adhesions, right? One adhesion is from previous surgery. So previous surgery can be from endometriosis surgery, but actually they remove all endometriosis surgery, especially long time ago, some of physicians doing the open surgery for endometriosis. Open surgery creates more adhesions. So that's why that adhesions, you cure the endometriosis, but your adhesions forming, this kind of non-endometriosis adhesion can cause pain. Then the other types, endometriosis itself forming the adhesions. So this one, you remove endometriosis, you will have to remove adhesion too. So there's two types of adhesions.
Okay, gotcha. What are typical post-op complications that patients experience, and what should they do if they do experience them?
So majority of post-op complications is we call complications, right? And we should talk about if involve which organs. So we talk about if you have a short-term and long-term. Right immediately after surgery, you can have a fever, that kind of complication, infections. This ratio is very low, normally less than 1% in our practice. So we normally show up 3 to 7 days. Then we need to do the imaging study and give antibiotic and treat it. And occasionally, very rare, we need to do the drainage, IR drainage, or surgical drainage. This is very rare. Most times treated in antibiotic. Then other one is the incisional infections or allergics. Though you can give allergic medication, and infection, you can give antibiotic too. Then long-term or severe complication, you can have bowel endometriosis, and you have surgery and bowel leakage and all these kind of things. Normally, we let the colorectal surgeon deal with this one. Then bladder complication, have bladder leakage injury, and urethral injury. So it's good thing. So all this complication is very low. So we done like 1,000 cases. We have maybe like 1 or 2 patients happens. But most time, if you have endometriosis on there, we do the surgery, it not happen complications. So it's very rare.
Yeah. And I do want to note that if you have complications, typically the hospital does give a nursing line number. And I know that a lot of patients always forget about that. So that's a great resource to use, is to call the hospital post-op nursing line.
Yes.
Especially after hours.
Yes, after hours, they direct to our on-call. So physicians and fellows.
Great. So I've seen a couple questions in here about endobelly. What are your thoughts on endobelly? Is surgery going to help resolve that? What can we do about that belly bloat?
Yeah, this is very broad, right? It's a very difficult treatment. And I have many, now have a lot, have endobelly. Like when you have a certain time, your belly like bloating up, like 3 months, 4 months. So one patient even have 6 months pregnant. So how we do it? So initial, we still have one patient employee. Initial, we do the hormonal treatment. It's not work. Then we talk to other specialists, and then they suggest remove the uterus. It not work. So it actually resolved for like 3-4 months coming back. Then I remove her ovaries. So she almost 47, right? She had adenomyosis. So we remove the ovaries, and her endobelly distended, released for 1.5 years. She now coming back again, not all the time, once a while. So we check the hormonal, we send to endocrinologist. It's not really we get the diagnosis why causing that, because now it's many times after first surgery and the second, third surgery, no endo anymore, because it's not endometriosis. And we will remove everything every time. We have any suspicion, no report endometriosis. So that's why I don't know why it's still causing. Now obviously we check hormonal, she's menopause, everything's in the long supposed to be, but still get a bloating. So this endobelly, we need to look into, maybe do more some research investigation. Hopefully, if other specialty have experience, I can get a share to us. This is really very difficult for us to handle.
Yeah, I have to say, I'm completely pain-free since having surgery with you. But I definitely have that bloat still. But and I think that there's a lot that we can do around seeing nutritionists, functional medicine doctors. And I think that, a lot of the symptoms of endo, the stress that it takes on our body, the medications that we take can really also harm the gut. And I think that that's something that maybe more patients should look into, is how do we heal the gut as part of our endometriosis healing journey?
So did you find someone nutrition helping you now?
I have not started seeing anyone yet, but Jessica Drummond of the Integrative Women's Health Institute is an awesome resource. She's someone that I'm looking into going to see. She trains nutritionists and health coaches who are often very knowledgeable about endo. She's written a couple books about endo, and they also, a lot of them work virtually. So even if you're in Houston and she's in Connecticut, you can still see them. So that's definitely someone that I would recommend looking into, Jessica Drummond.
That's great.
Let me see. Yeah, we have someone here saying perhaps endobelly is more related to inflammation and immune factors. Check out Jessica Drummond.
Oh, cool.
Okay, Andrea D, we are on the same page. Okay, so let me see. What about fertility chances and concerns post-op with excision?
So let's now recently have a couple of research show actually improve. It's significant improve. So before always research that it's not harm for fertility, but not significant improve. So basically we did have many patients after surgery get pregnant. So we normally recommend patients after surgery 3 months to try to get pregnant. So the chance get pregnant is the actually highest period is 3 months to 1 year after surgery.
Okay, so 3 months to 1 year is the best time to really try.
Okay.
Do you have any recommendations if, you know, someone isn't able to get pregnant during that time frame?
Yeah, so if you're not able to get this in this time frame, we normally recommend patients to go see the infertility physician. So that's another one about fertility, right? We now find out a lot of patients plan to do the IVF. So we normally recommend patients go to do the egg retrieval. It means to harvest the egg first. Because during this procedure, basically IVF had 2-part procedure. Harvest the egg, then put the egg in, implant. So harvest the egg, you have to use the high dose estrogen. So we normally recommend patients to do the harvest the egg first. Wherever they do it can cause the endometriosis, then we're going to remove it. Then after remove it, you get a nice environment for the baby. You put the implant the egg. So then you get, now more and more, actually now is a paper coming out, this support this concept now.
Okay, so from understanding, do the egg retrieval, remove the endo to make it a nice environment, and then you stick the eggs in. Okay.
And the baby have no endo environment baby.
Yeah. So harvest the eggs before endometriosis treatment.
Yes.
Okay. Let's see. We have someone saying Fertility Friday podcast is a good resource for this. Thoughts on, I know we need to wrap up, but we have someone asking, and this has come up a few times, about hormonal suppression treatments prior to excision surgery. You know, if you're trying to wait for excision, is it safe to be on hormonal medications like Dynogest long term? Is that going to interfere with the surgery? Is that dangerous to a person's body? What are your thoughts?
So actually, that's the research about it. So another one is my personal experience, right? I prefer if patient coming with the already on medication, but if you start the medication causes a lot of pain, we just let you go doing the continue doing the medication. But if you can tolerate pain, I normally don't want them to do like medical treatment. We just want to find all endometriosis during the surgery.
Yeah.
So that's why I personally not suggesting patient to do because you want the surgery, you do the like Leopron or any treatment. No, we just go into do the surgery. Hopefully that time when we do the surgery, we can see all the endometriosis, then we can remove all.
Right. Okay, so if you can tolerate the pain, then stop the medical therapy to make it easier to visualize the disease. Okay. And then, so are y'all doing telehealth?
Yeah, we're doing telehealth for the initial visit, but we normally prefer to have pelvic exam. So the reason why we just incidental couple patients, there's one patient, not only one, many patients, other specialties sent to me because we're in the same floor. And they came, they said, oh, Dr. Guan, I did an examination for you. So it's fine. You just go in to remove the fibroid, do the hysterectomy. So I said, oh no, just send to my office. I'm going to check her. So I check her and stage for endometriosis. I have to cancel surgery right away and do the bowel prep, get the colorectal surgeon involved. We do the full surgery with the bowel resection. So that's why many patients we miss because they no pain, right? So they just because of fibroid they coming in, if you not do the physical exam, sometimes you can miss a lot of disease and especially advanced disease, if you're not aware. So we do telehealth, but if you're the first visit, we still do, after telehealth, we still prefer to come in for the pelvic exam and make sure consistent with. Then about like if we do the imaging study, then we completely can do the telehealth. So yes, we do a telehealth.
Yeah. But yeah, so you did the telehealth, but it's also really helpful diagnostically to have that pelvic exam.
Yes.
Okay, great. Okay, so our last question that we're going to take is a question about CA125. Is there any concern if CA125 is still high post-surgery?
No. So let's say CA125 is kind of marker. It's not tumor marker, or it's not really marker for endometriosis that's specific. So because many diseases can cause fibroids, even liver disease can increase tumor marker. So many diseases can cause it. So that's why it's so non-specific. So about tumor marker follow-up, there's no data support. So that's why we not do CA125 at all, except if you suspicious for ovarian cancer.
Gotcha. All right. Well, thank you so much for joining us. This was a really great talk. And we definitely want to have you come back and do more talks in the future. If you're interested, that would be fantastic. So happy Endometriosis Awareness Month, everyone. Don't be silent about your disease. The more awareness and the more correct information we can get out there, the better care that we're going to be able to get for ourselves and for the people who come after us. One great way to spread awareness is to get your Guan Gang gear. So our Guan Gang family, you can order shirts. I'm going to pop the link for our fundraiser in the comments. Our fundraiser is going to be ending on Monday. All proceeds go to support the Endometriosis Foundation of Houston and let us continue doing the work that we do. We're hoping to get some programs out this year to support our community. And thank you so much, Dr. Guan, for lending your face to our campaign.
Thank you.
So thank you so much.
Okay, thank you all. And my honor and happiness to do this. And always we can do more again. More than happy to answer the questions and more topics. Okay.
Definitely.
Thank you.
So, thank you so much. And thank you everyone for attending.
Have a nice weekend, everyone. Bye.
You too. Bye.